Our first speaker is going to be Linda Jacobs, who's the clinical professor of nursing and a true trailblazer as director for the development of cancer survivorship, clinical programs, research and educational initiatives at the University of Pennsylvania Abramson Cancer Center. Dr. Jacobs will present an exemplar for advanced practice provider dedicated survivorship and follow-up care clinics. Dr. Jacobs?
Use this to change.
Change, reverse, and laser.
This goes forward.
This one.
Thank you. It's my pleasure to be here today with all of you. I just needed a little bit of tech understanding here. So a few people mentioned that they would be repeating things that maybe were mentioned in previous talks. So I too am going to just very quickly identify a few things that all of you have heard about and probably have read, but they're sort of critical to where we are today. So I have listed here the IOM report meeting in 2005, the ASCO Future of the Oncologist Workforce in 2006, and then the IOM, this meeting, Ensuring Quality Care Through an Oncology Workforce, the meeting in 2008. At the bottom of the page, you'll see the documented their references, which are a year later when their reports came out. So pretty much from all three of these reports, the overarching question was, among many questions, who will care for cancer survivors in the future? And the recommendations across the board, if you read these reports, was changing traditional models of care, meaning changing how we provide care or figuring out a new way of doing things. And one of the things that rose to the top in all three of these reports was integrating and expanding the role of APPs within the collaborative or team-based care model. And I didn't even see the other talks that were given this morning. I didn't see those slides prior. So very briefly, I'm just going to zip through these slides. This was the IOM report in 2006, and probably you're all pretty familiar with that. And it was really very beginning of pushing cancer survivorship care forward. How many survivors receive comprehensive care? How can the transition happen? And what should patients primarily be getting in this care? Then you have the ASCO workforce meeting, and the key findings, someone else had these on their slide this morning, I think it was Larry actually, but one thing I want to focus on is in the second paragraph, the increased cancer survivorship by 81%, they were predicting was going to happen by 2020. And we're well on our way. And by 2020, here's the graph of that 81% increase. And you can see the oncologist survey, 68% were providing continuing care to their patients, which, question mark, could it be provided in another way? And then the down below, it'll say collaboration with primary care providers and use of PAs and NPs, best practices for survivorship care. The question is, okay, that was in 2008, that report came out, and where are we now 11 years later? Have we followed those recommendations? I'll leave that answer to the audience. And then we get to the workforce meeting, this meeting, 10 years ago or 11 years ago. And some of the issues that are in print in that report are any model of cancer care and survivorship care that does not take these things that I've listed here into account will likely not succeed in meeting the needs of the patients. And they have there, considering the things that we've talked about this morning, the oncology workforce, the PCP workforce issues, the complexity of cancer care. And at that time, we didn't even know how complex things were going to get 11 years later. And then the need to provide care both in academic as well as in community settings. And one thing that was proposed at the meeting, and I have to say I'm the one who proposed it, so I'm going to put it up here, was utilizing the integrated care model. And that was survivorship follow-up visits in all oncology collaborative practices. Collaborative meaning oncologist and a APP working in conjunction. APP survivorship follow-up visits at the end of treatment, as well as yearly. The person who's been following them just can continue to follow them. And then should patient get some kind of treatment summary? I'm not advocating for something that we have to, we've currently been involved in, which I won't really get into. That's another whole topic. Referral to primary care. should patients be referred to primary care? That was a question. And the reason I have it highlighted here with variable timing and disease specific is that over the last 11 years, we've really learned a lot of things about transitioning patients, including the fact that every patient cannot be transitioned. In fact, many patients cannot be. And we really look at risk stratified care. What level of risk is this patient in terms of disease recurrence, late effects of treatment creating a problem or another disease? And even the things we knew back then, we didn't know nearly what we know now in terms of how frequent patients would be coming back with new diseases and lots of new problems. The other thing was education, information dissemination, patients, primary care providers, other subspecialists, families, and doing some outcome evaluation, looking at the metrics. So that brings us to today. That was pretty quick history. Where are we today? And I'm going to present to you an overview, a really quick overview, because I don't have that much time, of the program we have established at Penn. And it didn't just become established. I've been there since 2001 attempting to do this. And I say attempting because it's been a pretty steep uphill climb for a lot of reasons, and many of the reasons were things that were mentioned this morning, including resistance from administration and other providers needing that, what I kept being told, the feel-good visits, so they couldn't transition patients. They wouldn't want anyone else to see them other than themselves. They needed them in their practices, et cetera. And then also reimbursement was an issue. So I can't say we didn't make any progress over the years. We made a lot of progress, but it was slow, gradual, with just a few diseases. And only in probably about 2016, and it coincided with leadership changes in terms of recommendations and requirements, that we've made more momentum. So between 2016 and 19, most of these things have gone full force into effect. So the goal of this has been improving patient care through clinical practice reorganization. We've heard that phrase this morning stated in several different ways, but what we've called it is clinical practice reorganization, which nothing gets more resistance than telling clinicians that they need to change something. Even before they hear what it is, they don't want to hear anything about having to change anything that they're comfortable doing and that they have been doing. However, better survivorship or follow-up care would result, increased new patient visit slots in schedules, as well as increased ability to manage on-treatment patients, which is critical. And it required both provider as well as administrative buy-in and support. So you can imagine how difficult something like that would be. And I want to draw your attention to the first line where I said better survivorship / follow-up care, because what I've learned over the last 17 years is that sometimes people don't want to hear about what we're calling survivorship care. And in reality, all it is good cancer care. It's good follow-up care. All cancer patients should have good follow-up care, whether or not they're still in treatment, whether they're metastatic and getting maintenance therapy, or whether they are, quote, disease-free of sorts, or at least what we think may be disease-free. So, at Penn, the principles, oncology APP-led follow-up clinic. Again, we did get some physician, and administrative support. And the way we did that was I presented to each one of the disease group being the breast group, colorectal group, et cetera, their leadership meetings, presented what we wanted to do and how we wanted to do it. We pointed out that the APP would not be a separate clinic necessarily. It would be within the disease group, and it would be within the oncology practice setting. And it would be separate to some extent from the acute care treatment in those particular visits would not be the patients who are currently in treatment. They would be post-treatment patients. And also pointing out, someone mentioned radiation oncology. The disease group leadership is radiation oncology, surgical oncology, medical oncology. And buy-in had to come from all three groups because they're all part of the team. And within that group, you have the APPs who work with each of those different disease groups and different entities. What we had it such that we had APPs self-identify who's interested in doing follow-up care in addition to what they already do. Again, not requiring hiring more people, not requiring changes in that way, but someone who could possibly take on one session, arrange it so that they saw just follow-up patients. And we wound up with about 20-some APPs. Some of them are in medical oncology. Some, they're living in radiation oncology. For example, our prostate follow-up clinic is in radiation oncology. And some are in surgery, such as our bladder cancer patients mostly stay in the urology groups and are seen by APP follow-ups there. So again, good survivorship care is good ongoing follow-up care. So the practice structure, again, as I said, is within the oncology practices. The APPs who decided they wanted to do this, we had to get buy-in from each of their leaders, whoever hired them, whether it was radiation, surgery, medicine, and they had to, we sold it by saying it would be non-redundant, efficient care supported by our pathways. And the pathways are an ongoing development. And what we proposed was that the APPs would be the ones responsible for developing and putting into place the follow-up part of the pathway. So we actually had a working meeting, this was over a year ago now, where we did nothing but develop pathways, and then they continued to do that within their small disease group, vetting it past the rest of the people on the team, meaning the oncologists, the other nurses, the pharmacy group, whoever was part of the leadership team. And we used the guidelines that are listed there. And one thing that I have listed at the bottom, sort of the dirty word, is financial decisions to support this. How are you going to support this? I was asked that many, many times from different groups. And the way I sold it, again, was to say we're not hiring more people. We're just reorganizing the practice so that the people who are currently working in the practices can be the ones seeing the patients and working with the team. So the models of follow-up care, you have the end-of-treatment patients, and then you also have the long-term follow-up patients. The long-term follow-up patients in the long-established practices, we could have a single provider with 40 follow-up patients on their schedule in 1 week. I mean, that sounds shocking, but it is. And I mean long-term follow-up, people who are sometimes in the 10 to 20-year range out of treatment. Now, should those patients be transitioned to primary care? I'm not going to answer that because actually you're not going to convince people to leave a comfortable place where they feel like they've been cared for, diagnosed, provided for 20 years and say, no, we're not going to see you anymore. The goal was to have them comfortable with what the transition would be. So for the short-term follow-up patients, it was, that we needed to meet some guidelines and we wanted to have patients get survivorship care plans. And however, we've really adapted that into it being their visit note being their care plan, meaning better note-taking, better documentation within the confines of what we have in Epic. Now that we share our notes with patients, patient is on the patient portal, they can print out their note and have the summary of everything that happened and what the recommendations were. We learned through multiple research projects that we had running, as well as lots of things in the literature, that you're almost going to fail if you try and impose more work on providers and tell them you must do this in the visit. So we're trying to make it easier and make it part of the visit. So the visit itself becomes the survivorship care plan. So metrics in terms of, are we successful with this? And I didn't put numbers and give you all the things I could have given you because of in the interest of time. But we have gotten and we continue to get data to support the implementation sustainability of this. And that's why we're actually successful. And we are slowly decreasing new patient wait time and increasing new patients. One thing that my argument I've made to the administration has been, right now, many of the schedules are double and triple booked. You have to decrease the double and triple bookings before you're going to add on new patients. So often the new patients, have remained static, and we're not necessarily seeing those changes yet. But we are seeing decreases in the number of double and triple booked by having the APPs taking those follow-up patients from the schedule. And then again, improving patient satisfaction. We've had little to no backlash from patients not wanting to see someone else, thinking they were being turned over from their provider. It's done in a very seamless way in which everyone's in agreement. And it does increase revenue. We've had our numbers people look at how many new patients could potentially come into practices if these things were put into play, and what it would look like down the road in terms of bringing new patients in, scans, labs, hospitalizations, et cetera, of those new patients. And the numbers are staggering, what it would bring to our health system. We're a matrix center, so it's not a freestanding cancer center, but we're talking all the services, endocrine, et cetera, surgery, everyone. And I put this slide here because I just wanted to point out that the center is the core of our program, where there's a number of employees, and we work together. That's our team. But the people around are critical to the care of the patient. And I have those particular things listed there. And they're not there just because we know those are the disciplines that we need, but they're because over the last 10 years, we've established relationships with people, providers in these groups who have said, we want to see your follow-up patients. And many of them have put aside like one session a week, where if there's a patient the week before, they need to be seen, you can get them in a week or two because there's slots for them. Whereas, like someone mentioned, you might have to wait 6 months or 3 months to get an appointment in endocrine, or an appointment in dermatology. That's another one. But now we have people who will see them pretty quickly, but it's developing relationships with those people. And some of the lessons we've learned, not easily, have been that all patients definitely should have primary care providers. And we do not transition all patients out, as I mentioned before, just some of the very low-risk patients. And we've done that because we've learned they wind up coming back. And and a lot of the patients don't want to do it. A lot of the primary care providers don't want to see those patients. Of course, there are a group that will and are willing, and we utilize many of them. And the ongoing challenge has been we need better help from technology, and we've heard some of that this morning. So our goals for this year and moving forward are really further development of guidelines and our pathways. They're an evolving process, as I mentioned. You don't develop pathways and then that's it. They constantly are changing. And ongoing education for our providers around risk stratification. What does that actually mean? And continued endorsement by our leadership group to advance utilization of our follow-up clinics and the APPs. And in terms of technology, this is a whole discussion which I won't even get into, but just having the ability for the EHR to better populate things, for us to be able to, can they give us a list of ABC? Can they tell us lots of information that we really would benefit from having? And I know it can be done. It just hasn't been completely operationalized, I should say, so far in our setting. I just want to also mention, as an aside, that our APP group, we meet monthly. We have retreats. We have working groups. Our next working group is focusing on EPIC and having 2 EPIC educators coming and helping us figure out how to put together better ways to get information, cull information from the electronic health record. And the APPs are also sitting on more committees, sitting on more teams, and being active players in this role. And I say APPs, I do mean physician's assistants as well as nurse practitioners. We have a combination of both. Thank you.